bird on a tree.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. كما عودناكم على استمرارية النشاط العلمي لمستشفى الطب النفسي التخصصي بمدينة الملك سلمان بن عبد العزيز الطبية بالمدينة المنورة، بالتنسيق وبالشراكة مع الشركات الأدوية الداعمة. يسرنا في هذا اللقاء المبارك في هذا المكان المبارك بجوار مسجد رسول الله صلى الله عليه وسلم أن نبدأ هذه الندوة العلمية. اليوم محدثنا المبدع الدكتور خالد العوفي، وهو ما شاء الله تبارك الله كين وحريص جدا على تقديم كل ما من شأنه نشر المعلومات والخبرات للآخرين. يعتذر منكم الدكتور حسن أمان، كان المفروض يكون معنا بس حجزه المرض، شفاه الله وعافاه، لكن إن شاء الله الدكتور خالد فيه الخير والبركة. وبعد كده الدكتور حسين جزاه الله خير حيكلمنا برضو عن البرودكتس اللي عندهم ويسوي نفتح المجال للدسكشن. تفضل دكتور خالد. مرحبا.
Today, inshallah, will be about ADHD in adulthood. ADHD is a common disease that is with the onset in the childhood, but also it can continue until adulthood. So, Bismillah. Attention defect hyperactivity disorder is a neuropsychiatric condition affecting preschoolers, children, adolescents, and adults around the world, characterized by a pattern of this diminished sustained attention and increased impulsivity or hyperactivity. Previously, it was thought to be excluded to young children, but later it was shown that adults can also have ADHD. Etiology of ADHD is largely genetic, with a hereditability of approximately 75%. ADHD symptoms are a product of a complex interactions of neuroanatomical and neurochemical systems. There are genetic factors, neurochemical factors, neurophysiological factors shown in EEG abnormalities, and neuroanatomical aspect, which was proven to be by imaging studies, and developmental factors, mainly mothers who have infections during their pregnancy, especially in the first trimester, might have children with ADHD. Psychosocial factors as well, severe and chronic abuse and neglect shown to increase ADHD symptoms in children. ADHD in adulthood, our topic for today. ADHD was historically believed to be a childhood condition, but later it was found that up to 60% of children with ADHD will persist to have the impairment into adulthood.
عيدها مرة ثانية هذه يا خالد. كم نسبتهم؟
60% of children who have ADHD.
مو زي زمان.
Yes.
زمان كانوا يظنوا small amount، يعني 60% أكثر من النص.
Yes.
And
for adolescents, up to 85% will have between 60 to 85% of adolescents will have ADHD during their teenage years. Genetic studies and brain imaging and neurocognitive and pharmacological studies all shown that ADHD shown in adults is the same disorder as the ADHD they might have in their childhood. Epidemiology among adults, this is specific for adults. Evidence suggests that an approximate 4% prevalence of ADHD in the population. ADHD in adulthood is generally diagnosed by self-reports. There are websites that are designed for self-reporting ADHD. Also, there is a test for self-reporting, could be done in the clinics. But there are difficulties to make accurate diagnosis because it relies on the history, and we do not always have this information from the schools. it might not be noted from the school how the child behaved during his early school years. This is the diagnosis based on DSM-5. At least 5 symptoms. This is for adult, 5 symptoms. For children, at least 6 symptoms. So at least 5 symptoms per category in adults for at least 6 months, and it has to start before the age of 12 and to be noted in 2 settings with impact on social, academic, or occupational functioning. And it should not be better addressed as another mental disorder. So the patient need to have 5 criteria from here and 5 from here to have a combined ADHD. If the patient will meet the criteria in only one of these 2 groups, then it will be attention defect or hyperactivity ADHD. So it will not be a combined. So we have 3 sub classification for ADHD: attention defect, hyperactivity, and combined disorder, based on which criteria the patient can meet. Differential diagnosis for ADHD. The main differential diagnosis is the bipolar affective disorder, especially type 2, because ADHD symptoms can be similar to hypomania and mania, non-severe form of mania. So the diagnosis of ADHD is likely when symptoms are lifelong symptoms. If it was noted the patient had these symptoms for a long period of his life, then we might suspect ADHD. But if these symptoms are episodic in nature, this can be if these symptoms are noted for an episodes only, this could be an indication for bipolar disorder. Also, adults with an early history of chronic school difficulties related to paying attention, activity level, and impulsive behavior are generally diagnosed with ADHD. So it is important to focus on the children since the school and preschool, and note everything that might have a significant medical use later, so we can have a better understanding for the history of our patients. Anxiety disorders also can coexist with ADHD. Actually, a patient with ADHD diagnosis have increased comorbidities of anxiety and depression. So anxiety is common, but it can be differentiated and distinguished more easier than hypomania. Causes and prognosis. The prevalence of ADHD diminishes over time. So people who have ADHD as children might have fewer symptoms when they grow up. When they, as they go into adulthood, they might have less and less symptoms, especially if they are treated, and it is treatable. It's a treatable disorder, so it can be treated. And nowadays, the awareness of ADHD has increased. So people can detect this disorder since an earlier age and seek help and treatment for the children from an early age. Treatment of ADHD in adults targets pharmacotherapy mainly, and mainly long-acting stimulants. Actually, the only approved medication for ADHD in adults are the long-acting stimulants. The short-acting stimulants are only approved for children. This is according to FDA approval. Signs of positive response are an increased attention span, decreased impulsiveness, and improved mood. These can indicate that the patient is improving on our treatment. Here we have this list of medications that are approved, FDA approved for treating ADHD in adults. And in our practice, we mainly use methylphenidate, 18 milligram once a day as a start. And this is according to many guidelines, this is the first line of treatment for ADHD. Also, psychotherapy can be helpful in ADHD, so the patient can understand some of the difficulties he's facing in his life are related to his ADHD condition. Thank you. شكرا. Dr. Tayyib has an
input.
yes regarding ADHD.
اوكي خلاص بسم الله بسم الله.
I will not take much of your time. So the topic given to me was to differentiate between the ADHD and the bipolar, because there are much common comorbidities and there are some similarities and there are some differences. And let's start the presentation. So, okay, so the roadmap that we are going to take, first we will not go deep into ADHD, but we'll have some points. Then we will go towards the similarities and differences between the ADHD, and then we will discuss some of the treatment modalities available to treat the bipolar affective disorder and comorbid with the ADHD. Now, as we already see the slides from Dr. Khalid regarding the diagnosis, few of the important things that when we say that adult onset, actually it's not adult onset. For a diagnosis of adult ADHD, you have to have some symptoms present before the age of 12 years to diagnose adult ADHD. You cannot just diagnose in the adult and say there was nothing there before. Why I am making this point? This is a point important to differentiate between the bipolar and ADHD. So one of the points. The rest of the symptoms are the same as told by Dr. Khalid. So you will have 5 symptoms of inattention, and symptoms of hyperactivity. So 5 from there, or either any mainly from one cluster. We'll go some points, the inattentions, wandering off the task, lacking persistence, difficulty sustaining focus. He is disorganized, and this is not due to the defiance or lack of compassion. Hyperactivity, there is excessive motor activity, fidgeting, tapping, talkativeness, extreme restlessness, especially in the adults, and they will frustrate their peers due to their elevated activity levels. Impulsivity will have actions, as we know, that they will do hasty actions without thinking about what could happen in their future. There is, for that purpose, they will have high potential for harm to others and for themselves. There is social intrusiveness. They will not think before going to a social gathering, and they will start talking before any, they will not care for the social norms, and this can impact their major life decisions. Now I will give some of the percentages. So ADHD is 5% of the children and 2.5% of the adult, more frequent in male than females. Now the point, the 50% of children with ADHD will experience attenuation of the symptoms. So their symptoms will be milder when they reach the adulthood. And basically, okay. So the other percentages, when we talk about the adult ADHD, it is 2.5 to 4% of the population. Now the adult with ADHD have 4 to 9% high prevalence of comorbid mental health diagnosis. In case of bipolar affective disorder, we can see it can reach up to 20%. So the progression of symptoms, it begins in childhood. The hyperactivity predominates in preschool age children, identified in elementary schools. And in elementary schools, you basically have more inattention than the hyperactivity. Hyperactivity will improve in adolescence and adulthood, but restlessness, inattention, poor planning, and impulsivity, it will persist. So the childhood ADHD persists in the adulthood in a percentage between 15 to 60%. In contrast, if you will see the patient with the bipolar affective disorder, they will have 10 to 20% ADHD diagnosis. That is usually missed and will result in some sort of the symptoms unaccounted for, and sometimes you will be thinking maybe we missed something, still some baseline, either the baseline is high, some hyperactivity in their personality, or maybe the bipolar is not fully treated and we are giving higher medication and we are not thinking about the ADHD in bipolar patients. Now we're coming to the main topic. So as you can see that ADHD is a diagnosis where the symptoms will start in childhood. In contrast, in bipolar affective disorder, we will have the first manic episode in early adulthood, but there are some studies they will saying that some of the patients are hyperactive in the baseline, but they are not coming in the diagnostic criteria. The course is stable in ADHD, it's not waxing and waning, except if we have some stressors in the family that can change their moods. Except that the course is stable, it will start and it will run. In contrast, the bipolar affective disorder is episodic in nature. Now coming toward the symptoms, in ADHD you will have a labile dysphoric mood, and now we are comparing the bipolar hypomania or mania. We are not comparing with the depressive components of the bipolar affective disorder. So you will see the mood can be persistently euphoric, elevated or irritable mood. There will be reduced self-esteem in ADHD. In contrast, in bipolar manic or hypomanic, you will have inflated self-esteem or grandiosity even. In ADHD, you will have a distractibility. So you will perceive when you talk to them that he will have a thought wandering, and you will talk to the patient. It is different from the bipolar affective disorder, because in bipolar affective disorder they will explain their symptoms in terms of acceleration of the thoughts. So they are in terms similar, but at the same time they are dissimilar when you go in details about the thought process. The ADHD will have more restlessness, fidgetiness, and but the bipolar, in case of hypomania, mania will go again into the restlessness and other things, and the goal directed activity is not there anymore. But at least in hypomania you will have more goal directed activities. Sleep is usually not affected in ADHD, but when it does, for example, certain patients with ADHD, when they are taking stimulants, their sleep is disturbed, but what they will suffer is lack of sleep, and they will be tired in the morning. So they will have more need for sleep. In contrast, the bipolar affective disorder, they don't feel the need to sleep, so there is a decreased need and increased energy levels. The sexuality in ADHD is usually not affected, except for example comorbid personality disorder or childhood trauma. If it is alone ADHD, it's not affected. In case of bipolar affective disorder, we know that it increases. The psychosis is usually absent in ADHD, except for some of the patients who are taking stimulants and side effect of stimulants. They can have a brief episode of psychosis. It will not be persistent one. It will have clearly association with the medications. But in bipolar affective disorder, we know that this is a very characteristic portion of bipolar, and it will come in forms of grandiosity or other psychosis. Again, some of the clusters I already discussed. Some of them they are different, but some of them they will share the symptomatology between the bipolar and ADHD. It's a very crowded slide, but I think I already presented some of the points from before, so I will not go embarked on that. So the last slide we will be discussing the pharmacology. So there is not too much detail on how to treat a comorbid disorder between ADHD and bipolar affective disorder, but as a general rule, because not too much research is done in this area, but whatever there is, what they say is first you have to control the bipolar affective disorder, probably because in the adulthood or in the children there is FDA approval for the antipsychotics, so you will control either with the atypical antipsychotics or whatever. First you have to control the bipolar affective disorder, then you will go to treat the ADHD ADHD symptoms. The major concern from the psychiatrist is, for example, you are going to give stimulants, it can increase dopamine, it can cause psychosis, you are going to give atomoxetine, it can precipitate a manic episode because generally it is affecting on the serotonin receptors, but the research, whatever is available, is saying otherwise. It says that there is patients who are comorbid, first to control the bipolar symptoms, they are effectively treated with these stimulants. So they are, if there is a need, they will treat effectively with the stimulants. In case of early childhood, they will recommend the A2 agonists like guanafens and clonidine, and they're all approved FDA. Thank you.
Welcome everyone. Thank you very much for attending today. Thank you for Dr. Ahmed for this gathering. And first of all, I will introduce myself. My name is Hussein Al-Nakhli. I'm an Abbott medical representative. I'm responsible for the Vavrine. Today's presentation, I will discuss regarding one indication of the Vavrine, which is the depression. You might know the Vavrine from the usage in the OCD. Also could be used in the depression and other indications. So we'll just focus and highlight on the depression indication and how to find the balance for your patients. So I'll take only 10 minutes of your time. I will discuss the Vavrine from 3 points: efficacy, safety, drug-drug interactions. Then we're gonna highlight the indication, the psychotic depression. Finally, we're gonna conclude. So this is just an introduction regarding the depression itself. I'll not take long time. You all know about it. You all know about the morbidity, not the morbidity, the prevalence of the disease. It's estimated around 350 million people worldwide have the depression. The second cause of disability worldwide, and also consider about 80% of the patients on clinical depression who have received the treatment improve over in their life. So it's very important to manage such patients, and I'm here just to send some points regarding the Vavrine and its use, so that it can you can decide for your patient which medicine is best for him and find the right balance for the patients. So this is the Vavrine, the fluvoxamine. We're going to discuss the first point, which is the efficacy. I'll just highlight two main trials focusing on the efficacy of the Vavrine. The first one was comparing the fluvoxamine with the fluoxetine, and the endpoint of this trial was the fluvoxamine was superior to fluoxetine in terms of onset of action and improvement of sleep quality. So these are two main points that this trial came up with: the onset of action of the fluvoxamine over the fluoxetine and the improvement in the sleep quality. Another trial in severe depression patients also was assessing the fluvoxamine in compared to the imipramine, and you could see that the fluvoxamine was more effective than the placebo and the imipramine in patients with severe depression as well. So this is the second trial that was assessing also the Vavrine versus the other SSRIs. Well, another indication also in patients, or another patient who have mixed anxiety and depression. So Vavrine was favorable for those patients, as both Hamilton depression and Hamilton anxiety was in correlation. They were decreased in correlation to each other. So the reduction of Hamilton anxiety score was highly correlated with the reduction of the Hamilton depression score in those type of patients. So also another indication, patients who have mixed anxiety and depression might utilize the fluvoxamine as their drug of the choice. Well, when talking about the safety of the fluvoxamine, fluvoxamine considered to have little affinity towards histaminic sites, towards cholinergic sites, little affinity for the dopaminergic and the noradrenergic sites, which reflects clinically in low incidence of adverse effects associated with these receptors. So basically, when we look at the fluvoxamine incidence of anxiety and agitation in comparing to the other SSRIs, we could see that the fluvoxamine have the lowest percentage of incidence of anxiety and agitation in compared to the other SSRIs. Fluoxetine have the highest, followed by villavalaxine. Then the fluvoxamine considered the lowest incidence of anxiety and agitation caused by the SSRIs. And as we mentioned before, that patients who have mixed anxiety and depression have a preferable effect with the fluvoxamine. Coming to the cardiovascular disease, which is associated with high incidence of depression as well, fluvoxamine has a good safety record in those patients with minor cardiovascular conditions. There is no clinically significant changes noted in the blood pressure, heart rate, and the ECG. So here's another point for the elderly patients, why we could utilize the Vafrine for the elderly patients, as it is not cardiotoxic, not sedating, and low incidence of anticholinergic side effects, not toxic even in overdose, and the low potential for the drug interactions. Well, in this trial, just like have the side effects, comparing the side effects for elderly and young populations. So they were assessing around 1,000 elderly depressed patients who were over 60 years, and around 4,000 young patients with the fluvoxamine. They came up that the overall incidence of the adverse effect was similar in both group ages. So this study just to say that the side effects is similar between the adult and children and young patients. As of the weight gain, the Vafrine doesn't cause the weight gain. It has natural effect on the weight gain in comparing to the other SSRIs such as paroxetine, fluoxetine, citalopram. All have a high level of, it will affect the weight gain on the long term. As of the Vafrine doesn't cause the weight gain and has a natural effect on the weight. Coming to the sexual dysfunction, which is another major issue concerned with all of the SSRIs. So we could see here that the fluvoxamine and escitalopram have the lowest level of sexual dysfunction in comparing to all other SSRIs. So when taking a look at a patient who is sexually active, you could consider adding fluvoxamine for such a patient, and you could utilize the fluvoxamine in this case. Coming to the drug-drug interactions, the fluvoxamine, we all know that the SSRIs and the cytochrome B450 interactions, the fluvoxamine doesn't have the interaction with the 2D6, unlike the other SSRIs. It only has an interaction with the 3A4 and 1A2 cytochrome B450 enzymes. So the advantage of the fluvoxamine doesn't interact with the 2D6 cytochrome B450 enzyme, which could be utilized with all of these medication as these medication metabolized by the 2D6 enzyme. Well, to conclude with the psychotic depression indication, which the advantage and the major advantage of the fluvoxamine come here with the psychotic depression indication, as the Vafrine have the highest affinity towards the sigma-1 receptors. You might be familiar with the sigma-1 and its effect on the memory, learning, psychosis, aggression, depression, anxiety, stress, and pharmacodependence. A lot of studies have been conducted in that part and the role of the sigma-1. So the fluvoxamine considered to be the highest link to sigma-1 receptors among all of the SSRIs. So in this case, Vafrine also could be utilized and used when managing patients with psychotic depression and compared with the other treatment options. So With that, I can conclude that the fluvoxamine, significantly effective in the treatment of the major depressive disorder, have the least sexual dysfunction effects, and it's very well tolerated with the elderly patients. It has the least drug-drug interaction and plasma protein binding, and it has the highest affinity towards the sigma-1 receptors, which gives it the upper hand to be used in the treatment of the psychotic depression patients. So with that, I conclude my presentation. Thank you very much for having us here today, and it's a discussion time. Thank you.
عندنا مواضيع كده هي correlated مع بعض. ال ADHD in adulthood إذن it is misnomer إن نقول adult onset صح؟ it is يعني ADHD diagnosis of ADHD in adulthood لكن ما نقول adult onset لأنه لازم prerequisite لازم هو مشخص في الطفولة. وبعد كده ال differentiation between the major differential diagnosis of bipolar affective disorder في السلايدات اللي شرحها الدكتور طيب، وبعض الأحيان صعب جدا فتلاقيك أنت تحط الاثنين مع بعض. ها ويطمنا الدكتور طيب على موضوع إنه كان prescribe anti manic plus stimulant medication، لأنه نحن معظمنا متخوفين من الستيمولانت ميديكيشن لا تروح تزود الدوبامين تزود المانيك سيمبتومز. والدكتور حسين كمان ادانا هايلايت على الفافرين. نفتح المجال، تفضلوا. تفضل.
عايزين نتكلم كلينيكالي على النمبر اوف بيشنت ويز دايجنوز اوف ادلت ADHD. يعني عايزين نفتح النقاش في النقطه دي. انا شخصيا معايا حاله واحده بس فقط يعني، وهو ميديكال ستودنت suffering from mainly impaired attention and difficulties in academic function. والدايجنوز benefit from الكونسرت very well. فده الحل اللي معايا. عايزين نعرف النمبر اوف بيشنت يو ار فيسنج.
اي صحيح. دكتور نادر تفضل.
حالك مع هذا
والله طيب السلام عليكم.
السلام عليكم.
مر علينا كثير احنا في الجامعه خاصه في الكليه، وبتظهر فيري كلير في الكورس بتاعنا بتاع السايكاتري بالتحديد. we noticed a lot of students they have mainly inattention، يعني الاناتنشن اكثر من الهايبر اكتيفيتي. الاشكاليه بتكون في الدايجنوزيس ان تو سيتنجز، يعني احنا محتاجين تو سيتنجز اللي هو الهوم والاريا بتاعت الان اتنشن، مثلا السكول في التشايلد هود. لكن في الادلت هود هل اليونيفرسيتي is it an appropriate area for setting to diagnose الان اتنشن؟ لانه الكونتاكت يعني فيري شورت، ما زي المدرسه الكونتاكت مع الاساتذه والحصص بتكون واضحه والاكتيفيتيز. هنا يعني التشالنج بيكون في الحته دي. في عدد، لكن يعني عدد ما بسيط، ما بسيط.
صحيح. انا شايف ان هي الدايجنوزس في الادلت ADHD هيكون مينلي في الهاي انتليجنت بيبل، لان هم اوير في قصه الامبيرد اتنشن، واوير في الديتيريوريشن للفانكشن بتاعتهم.
اي
فده لكن ممكن تعدي بشكل عابر اندر دايجنوز
في الاذر
هو على اساس ان هو ممكن يتشخص نيجليجنس يعني.
اي
الان في نسمع بقى
regarding the bipolar comorbid with ADHD, because I never preferred patient with ADHD prescribing them the stimulants. It's not available, easily available. But I think the key to this point before any diagnosis is more important. But I told you the same point that comes in the differentials, also the similarities. So, for example, if a patient comes to with inattention, the main point is the diagnosis. Then you go for the treatment. So, the diagnosis, you have to have something before in the childhood, and you have to take history from one of the family members. You have to check the school records, because for the doctors, for the students, this is very sensitive. Some of them may be because of their knowledge problems, because of their language problems, they will sit in the college and they will have inattention time, right? They cannot concentrate properly because they are not able to understand. So to differentiate between this and to differentiate a true inattention because of the ADHD, a family history might help. Interview with the family might help. School records, they might help. But if there is a diagnosis, then yes, you have to treat.
Do you have actually now ADHD adult?
No patient in current treatment, yes.
كان في one patient جاء ويجي الطوارئ بشكل متكرر في المستشفى. في عنده اللي هو التشخيص الكوموربيد ADHD وبايبولر، عنده تو diagnoses مع بعض. تقريبا in his 20s تقريبا في بداية ال20s يعني 24 23. وبرضه عنده drug abuse substance use disorder. حسب ما اتذكر كان الميديكيشنز اللي كان ياخذها انه ما كان فيها ستيمولانس، كان نفس الفكره اللي انت ذكرتها دكتور احمد، انه يكون في تخوف انه احنا نوصف له ستيمولانس، وكان
خصوصا انه هيز ابيوزنج دراجز،
خاصه انه هيز ابيوزنج دراجز،
فكان في الادلت.
فكان مره يجي بشكل متكرر. اتوقع ممكن قابلوا خالد او يشوفونه كثير، الاطباء اللي كانوا يشتغلوا في الطوارئ كثير، يجي كثير في الطوارئ عنده الكوموربيديتي هذا. واعتقد انه الصعوبه كمان في تشخيص الاي دي اتش دي اللي ذكرها دكتور طيب، انه التشخيص انه الاي دي اتش دي بيشنتس لازم نرجع قبل 12 سنه ونشخصه. الصعوبه الثانيه اللي تكمن في تشخيص الاي دي اتش دي في الادلت، انه اغلب الناس اللي بعد ما يدخلوا الادلت هود يصير ما عنده الهايبر اكتيفيتي، فيصير عنده في مشكله الكونسنتريشن، ومشكله الكونسنتريشن يقولوا له لازم تروح، يمكن انت عندك صعوبه في التعلم، ممكن انت ما تعرف تدرس زي ما باقي الناس ما يدرسوا، تكون سبب الكونسنتريشن هذه ممكن سيتويشن اي ما تكون كلير زي الهايبر اكتيفيتي، وبعض الاحيان تختفي الهايبر اكتيفيتي تماما ويبقى معاه الكونسنتريشن بس. والسبب اللي يخليه ما يروح قبل عمر 12 سنه تلاقي الاهل كمان وهم يقولون لا هو كان لعاب او شيطان قبل 12 سنه وعادي بيروح زيه زينا زي ما كنا احنا، وتلاقيه منتشر في العائله بشكل جدا كبير، بس ما في احد فيهم يروح. يقولون كلنا كنا اشقياء وكلنا كنا متحركين وكلنا كنا وراح مع الوقت، ويبقى حتى الكونسنتريشن، وتلاقي كل العائله في عندهم مشكله في الكونسنتريشن. فاعتقد انه هذا كمان
الجينيتيك لود 75%.
75% جينيتيك لود مره هاي.
But the biggest fear of the doctor is not the precipitation of manic episode. The biggest fear is substance abuse.
Yeah.
Your fear that he will go in abuse and he will be a problem for you and for the society as well. He will come repeatedly, he will make problem for everyone.
Sure. تفضل.
Bismillah. First of all, I came from a family with history of ADHD. As my mother described, my oldest brother had very severe hyperactivity when he was a child, but then it disappeared with time. Also his son, my brother's son, was diagnosed with ADHD. My own son is diagnosed with ADHD. And we are following with them, and they are mashallah doing very well at school. I had for patients, I had 3 patients with ADHD. I'm always concerned about ADHD. Whenever a patient mentions that he has an ADHD, I would open subject and talk with the patient about it. One patient I encountered in primary health care, one patient I met in the ER, and the most interesting case I saw in OBD, he was a CEO for a company, مدير تنفيذي, and he was on Concerta 36 milligram daily, and he was doing very well on his life, but whenever his medication isn't available, the patient goes into very disturbed and impulsive behavior and cannot concentrate, and has to take sick leave from his work. Yes, because he cannot perform as expected from a CEO.
جزاك الله خير. هذه مهمة sharing experience. أحلام برضو عندها بعض الحالات ال ADHD. تفضلي.
السلام عليكم جميعا. دكتور مصطفى، OCD personality و ADHD. تمام. كيف لفت موضوعي ل ADHD؟ كان في نوبة ديبريشن. تمام. بس طول الوقت بيتحرك على الكرسي. هو ديبريشن نايم على السرير بس طول الوقت بيتحرك في السرير. تمام. عنده ردود أفعال لا إرادية. في عنده تفكير وسواسي كمان. ففعليا لما عملنا التقييم وبعدين رجعت عملت المقاييس، طلع فعلا انه هو ADHD، خاصة انه 31 سنة شغال في الطب. تمام. هذا ساعد كمان انه الOCD كمان يتطور عندنا. ADHD كانت صعبة في موضوع الدراسة، كون انه هو طالب طب صعب انه هو يحصل على نقول معدل ثابت او كويس. فأجلنا الموضوع هذا بعدين لما نساعد انه هو يكون اكثر تركيز. بدأ على أدوية تساعد إنه هو ADHD كمان يهدى شوية. بدأ يتحسن موضوع الدبريشن، بدأ يتحسن موضوع الباي بولر كمان بناء على تحسن DHD.
في الحقيقة شكرا لك، جزاك الله خير. أي أنا في الشهر اللي فات عندي حالتين ADHD. واحد كلهم نيو كيس فور مي. واحد ميديكال ستودنت 20 في التوينتيز، مش ميديكال ستودنت، يونيفرسيتي ستودنت. وواحدة ثانية الايرلي 30s، هي موظفة وبرضه كمان هي جاية اسكينج، قريت عن حالتها. ولما سويت لها تقييم فأنا كنت في الديفرنشال دايجنوزيس بايبولار افكتيف ديس اوردر ولا هل هي ADHD. فهي هي بتقول لي دكتور انا حاسه انا ماشيه على ADHD اني اتنتيف تايب، ماشيه تبحرت وقريت قلت لها حتى وان كان نحن حنسوي البيز لاين اسسمنت، وحولتها السايكولوجيست عشان نسوي لها التقييم والكلام ده، وحتجيني ان شاء الله المره الجايه ونشوف كيف الوضع. دكتور نادر تفضل.
بالنسبه للتست والريلابيليتي اوف ذا تيست فور ذا ادلت ADHD، يعني لما تخش في الويب سايت او في الاونلاين بتلقى تيست كثيره جدا. which one is more diagnostic and reliable and recommended for adult ADHD for inattention and hyperactivity؟ لانه في a lot of tests a lot of variation. احيانا self monitoring تلقى البيشنت جاي بري اوكيبايد اساسا انه انا كده.
صحيح صحيح.
فدي بتكون مشكله احيانا they are misdiagnosed themselves and misdiagnosed by others. بس عندهم خلاص انا ADHD. how can we differentiate and improve accurate or يعني reliable psychometric test for adult ADHD؟ يعني
وهذه نحن نذكر انفسنا بالمصداقيه والثبات، reliability and validity of all psychometric assessment. ما في شيء اسمه قرآن منزل 100% صحيح. فساعد تقدر تقوم لنا بالمهمة بس نشوف لنا السايكومتريك اسسمنت للADHD، والخطوة اللي بعدها كم الفاليديتي وكم الريلايبيليتي حقت كل تيست. والنقطة السؤال اللي بعده في الادلت هود، هل هذا الكلام فقط في التشايلد هود ولا برضه كمان الفاليديتي والريلايبيليتي صارت دراسات على الادلت هود؟ فالvalidity and reliability of these tests in childhood and also in adulthood. يعني نحن بنتكلم على ال validated scales يعني approved medically.
أول كونرز صراحة
كونرز معروف.
ما عندي خبرة معاه وما اشتغلت. I think there is for adult. صراحة ما اشتغلت مع كونرز بس اشتغلت في فاندربيلت. فاندربيلت اعتقد انه في للتشايلد وفي للادلت كمان. بالنسبه لفاندربيلت اشتغلت في فاندربيلت في الامارات، كنا شغالين على الفاندربيلت انه احنا ما نقدر نشخص ADHD الا اتليست انه حتى الفاندربيلت سواء انه نوزعه للمدرس او للوالدين. يعني لازم في تو سيتنج،
لازم
التو سيتنجز حتى لها كذا البيرنتس والاذر سيتنجز للتيتشرز. غالبا حيكون الاذر سيتنج بما انه طفل غالبا حيكون التيتشرز. والتيتشرز غالبا ما نعطي وان تيتشر، كنا نعطي مالتيبل تيتشرز عشان يكون داعم اكبر لنا وقت الدايجنوسيس. واعتقد انه كان الفاليديتي عنده هاي بس حارجع اتاكد كم
شوف
كانت
لان هي
validity.
وشيرها على
كانت
الجروب.
مره فاليديتي
اي
فيها
شيرها على الجروب عشان المعلومه دي مهمه جدا. لازم نعيد انفسنا، حتى هذه سجليها عندك يا بنتي، الفاليديتي والريلايبيليتي، المصداقيه والثبات لكل السكيلز اللي بنستخدمها، وممكن حتى الاطباء يساعدونا في البحث عنها، ونحطها كده كفكر، نطبعها ونحطها عشان نكون صادقين مع انفسنا ومع المرضى. الناس اللي يجوا يقول لك اوه خلاص سوينا الاختبار يا ابوي الريلابيلتي حقه 70% مش. ايوه كونرز.
ايوه لحد الان تمام، ونروح له ونستخدمه على جهتين، الاب او الام او التيتشر
اي
والاطفال.
اي
فعليا للادلتس ما
I think the usefulness of this scale is more for the teachers and parents, because you want to examine in two different settings. For psychiatrists, this is the gold standard. He himself is the gold standard for diagnosing
Yeah.
the child if he has experience, he's trained in that particular field. But the scales available like Conners, there are certain behavior checklists available. This is mainly for the purpose that the parents and teachers can utilize these scales. These are based on DSM-4 scale, the symptom checklist. But regarding the details, I will check if I can have regarding the reliability.
Yeah, and
again,
validity.
You have to have it in Arabic language, because otherwise it is for the parents and the teachers.
اوكي. this is our help. في ايش اللي اسمه؟
فاندربيلت
اي موجود.
عليه موجود في العربي في
هل هو مقنن ولا فقط معرب؟ في فرق بين مترجم فقط ولا مقنن من
اعتقد انه مقنن، انه في اخر الورقه اتذكر كان في مكتوب عليه
فلان وفلان.
حارجع موجوده عندي، حتى موجوده عندي في البيت.
لانه في بعضهم تعرفوا ايش يسوي ترجمه ويقول لك مترجم، وهذا ما يعني لازم يكون اي بروفيشنال
في
يكون.
اختلاف بسيط حتى اذا كان نيو اسسمنت واذا كان في فولو اب.
اي
في اثنين فاندربيلت تيتشرز.
طيب عندك المقياس PDF ولا شيء ولا ما؟
اعتقد انه عندي.
اذا في ترسله على الجروب
عندي ورقه
على ورقه، حتى لو تدينا نسويه نحن هذا عشان يستفيدوا منه في العياده.
باذن الله باذن الله.
خلاص. اي
اطفال او ممكن تينيجرز تمام، عاده ادمج بين الاختبار بين كورنرز وبين اختبار الذكاء. تمام، عشان اختبار الذكاء عندنا بيبين اذا كان في تشتت، اذا كان في قله تركيز، اذا كان في صعوبات تعلم، وعاده هذه تتوافق مع تعطينا نتيجه كمان نقول مقاربه للواقع شويه.
انا كمان شباب لا تنسوا شيروا المعلومات، وحتى البرزنتيشن خالد وطيب حطوه على الجروب يور برزنتيشن. فكريني خالد حتى بكره قبل الظهر انا عندي اجازه بس شغال، انا عندي ميتنج الصباح قبل هذا عشان اتواصل مع في دكتور متخصص في تشايلد سايكاتري في مدينه الملك فهد الطبيه في الرياض، يمكن يفيدنا كمان بالسكيلز واشياء زي كده. فهذه برضو يذكروني نتواصل معه وما ما يقصر معنا. انا نختم ببعض الدول النورث امريكان كونتيننت في عندهم اوفر دايجنوزز اوف ADHD. اوفر دايجنوز، اي واحد جاينا على طول على ADHD. ومرضى كثير من عندنا من السعوديه لما بيروح هناك وبيروح الجامعات بيتشخصوا بيجوا على الستيمولنت ميديكيشن. انا عندي ماي بيشنت هو دحين خلاص اخر سنه في الطب، ولما كان في امريكا شخصوا ADHD ودوا له ستيمولنت، وهذول لما جاء انا شفت جنرالايز انكزايتي ديس اوردر ان اتنتيف ديو تو هي واز انكشس. فقال لي طيب هم شخصوني، قلت له لا، اذا تبي تسمع كلامهم متابع معهم، تبي تسمع كلامي امشي معي. وفعلا غيرت التشخيص وبديته على GAD وبديته على ميديكيشن امبروفينج، وقفت له الاستيمولنت وماشي تمام، يعني ماشي كويس. وبعض الاحيان يصير اندر دايجنوزيز برضه كمان، انه نحن ما بنفكر فيه كثير، نركز على الميجر باي بولر وسكيز والاشياء دي وننسى انه ان بتوين. فنحن انا افتكر نصيحتي لنفسي ولاخواننا الاطباء والسايكولوجيست انه في عاده مره حلوه نسيناها نحن شويه، لما نكتب التشخيص المبدئي نكتب التشخيص التفريقي ديفرنشال دايجنوزيس، كنا نكتب لما كنا طلبه طب نكتب 3 اقل شيء في الديفرنشال دايجنوزيس. دحين ما صرنا نسوي، نكتب على طول دايجنوزيس، لا لازم نحط الديفرنشال دايجنوزيس عشان هذه يخلينا يعني حريصين على انه ممكن نحط في انذر يعني ديفرنشال ممكن يكون في الموضوع. أنا أفتكر أنه ما شاء الله fruitful discussion. باسمكم جميعا نشكر شركة أبوت على رعايتها لهذا اللقاء العلمي، وشكرا دكتور حسين، وإن شاء الله دائما على مزيد من العطاء والإنتاجية والتبادل المعلومات والخبرات نلتقي. شكرا جميعا، شكرا، السلام عليكم.